So I'm going to talk about extracorporeal cardiopulmonary resuscitation, or e-CPR, as a lifesaver. No disclosures relevant to this discussion. So just to start off, a little background, there's over 350,000 annual out-of-hospital cardiac arrests, and the survival is about 7 to 12%. A quarter of these are due to pulseless VT, VFib, with the significant is thought to believe due to ACS. Now, 20% of these patients will have return of spontaneous circulation with hemodynamic stability, but you'll have 80% in refractory VFib, and these patients are going to die. So it's this patient population of interest in the refractory cardiac arrest patient population where innovative strategies are needed to bridge the patient from the field to the Cath Lab to potential revascularization and recovery. So this is where e-CPR comes in. So e-CPR essentially is ECMO as an adjunct to CPR. And as you know, ECMO is essentially cardiopulmonary bypass, and it perfuses the vital organs, and particularly in this patient population, it perfuses the brain, which is typically the rate-limiting step for survival. Here's a schematic of a ECMO circuit. We typically use a 25 French multi-stage venous cannula, and goes to the RA, IVC, takes the blood out the femoral vein outside the body in an oxygenator to pump outside the body, dumps it through the femoral artery into the distal aorta to perfuse. And this is obviously key because once a patient is put on ECMO, you could take a step back, take a breath, do your coronary angiogram, look for a potential culprit lesion to address that resulted in the ventricular tachycardia, or VFib. So, there have been a handful of studies published on this topic and showing e-CPR having encouraging outcomes in the refractory out-of-hospital cardiac arrest. But just to summarize some of these studies, first of all, low patient volume, as you can imagine. But essentially, the theme is that refractory VT, VFib is the sweet spot. These are the patients that have a chance for survival and decent neurological outcomes. The patients that are non-shockable, the PEA and the asystole, have very poor outcomes and poor neurological outcomes. So in our program, in our e-CPR program, we only include the VT, VFib refractory patients. So where do you start? Well, you got to bridge the patient from the field to the Cath Lab, and it's essential. You have to have automated CPR devices, because if you don't have this, you're not going to have good outcomes. So in the field, in City of Columbus, or the Columbus Fire Department uses the Lucas device, which is here as an example of a Lucas device. And the reason this is essential is because by the time you go from the field to the Cath Lab to ECMO, to perfuse all vital organs, it could be 45 minutes. And so you have to have adequate CPR. Just imagine flying down the street in an ambulance trying to give adequate CPR manually. And here's what happens when you don't. Here are two patients that came to us with the e-CPR alert. The one on the right, normal brain, survived, good neurological outcome, and went home. The one on the left, not so good outcome. This has diffuse cerebral edema, anoxic brain injury, and the patient didn't survive. So you have to have adequate perfusion, and that's where the automated CPR devices come in play. So when the patient arrives to the Cath Lab, you can see that Lucas device there on the video on the left. The first thing we do in our program is you get an ABG and you look for certain values. We look at lactate, we look at we look at the PO2, we look at end-tidal 2 CO2, and we have certain cutoff levels that we've made from our experience from other centers and from the data that's out there, and these are predictors of who may survive and have a good outcome. So if you meet these criteria, then ECMO cannulas go in, the patient's placed on ECMO, and then you can stop this automated CPR device and kind of take a step back and move forward with your coronary angio. So here's our protocol. This is a multidisciplinary protocol. It's in collaboration with the Columbus Fire Department. Earlier today in the session, I went through this in detail. This is all the inclusion criteria from the field to the Cath Lab to the ICU. If anybody wants this, I'm happy to share it with you. Please contact me, and I can provide it to you, email it to you. So let's go over a case. So this was a 52-year-old male working in his car in his garage. It was a witness cardiac arrest. e-CPR was initiated. EMS arrived, found to be in VFib, was shocked twice. Per the Columbus Fire Department, the third shock is a dual sequential with 2 pads that they do at the same time. If the patient is persistent VFib, that is defined as refractory VFib. That's when an e-CPR alert is called to our institution. The automated CPR device goes on. Patient's intubated, epi-amnio per ACLS, and then bypasses the ER and comes straight to the Cath Lab. In the Cath Lab, the e-CPR team's there waiting for the patient. And ABG is obtained if the criteria is met per some of the criteria I mentioned earlier. ECMO cannulas go in. Once the ECMO starts, automated CPR device stops, and you can do your diagnostic coronary angio to look for a potential reversible cause. Now, we didn't know much about this patient, but other than we did find out from ES on the way over to the hospital that he did have a history of coronary artery disease and a history of PCI in the past, but we knew nothing else. Okay, goes on ECMO, take a step back, take a breather, do the coronary angio, and you can see there's a stent in the proximal LAD extending back to the os of the LAD with stent thrombosis. So here's a picture image of the right, mild plaque. All right, so per our protocol, patient's gonna go PCI. If we have enteral access, OG, NG, you load with aspirin. We give ticagrelor for our P2Y12 inhibitor. If there's no enteral access, or your options are Canglor or IV, or most of us give a bolus of integralin. Buys you about 4 hours to get an NG tube down and then give your antiplatelets. We do these cases on unfractionated heparin. So moving on to the PCI, this was a patient, I was on call for this case. Wired the LAD, you can see reperfused, wired the circ, did manual aspiration thrombectomy due to the thrombus in the stent. And just for the fellows out there, just realize routine use of manual aspiration thrombectomy is a class 3. There is a class 2B indication. This is for the boards for select cases, which was done in this case. And if you recall, there was thrombus extending back to the distal left main down the circ, so manual aspiration thrombectomy was performed on the left circumflex. Here's the image post. And here we go, IVUS. Speaking of IVUS, so IVUS was performed and showed actually underexpanded stent. So stent was post-dilated. Sorry, these images are a little off here. This is the image post-dilatation, and here's our wire out shot. So post-procedure day 0, you can see some aneroceptal QAs. If you squint, you may see some ST elevation, very subtle, V1 through V3. Going through the hospital course, we discovered that the patient had a stent placed 8 months ago and was non-compliant with some medications, also history of hepatitis C. Urine drug screen was positive for cocaine, also alcohol abuse. The patient underwent temperature target management for 24 hours. Peak troponin was 48. Ejection fraction during the hospital stay actually showed preserved ejection fraction. Hospital day 4, ECMO cannula is removed. There was encephalopathy that improved by day 10. Likely alcohol withdrawal was contributing. Patient was extubated. Day 11, passed the swallowing study. Advanced diet. Day 12, physical therapy initiated at the bedside. Day 15, ambulating the halls. And day 16, the patient was discharged. You know, in our interventional service, we do meds to bed. And this gentleman, you know, for 16 days, couldn't wait another couple hours to get his meds, and he actually left against medical advice without his medications. So, in conclusion, e-CPR with the use of automated CPR device plus ECMO was a lifesaver in our patient with coronary artery stent thrombosis resulting in refractory VFib cardiac arrest. e-CPR has shown encouraging outcomes and is a promising strategy in this patient population, and I do think in the future there'll be more of these, more centers and communities with an e-CPR program, and thank you.